So thank you, for a really nice introduction, and it's really a pleasure to be here. I would also like to thank Dr. Karani, although I know she couldn't make it today. And I will stay very close to the podium because I've been told I'm being recorded, so I can't walk around because then those that are listening from Beth Israel and St. Luke's won't hear. So you're going to see me static and kind of holding on to try not to. So can everyone hear me at the back? Perfect. So today we're going to talk about a cause that's very dear to my heart because I'm a physician scientist myself. I have an MD and a PhD, and I do research and education and administration as a part of my career. And I actually am a graduate of the research track in the Department of Psychiatry here at Mount Sinai. So I can see in the background Reader, who was program director at the time. So he hired me as one of two physicians in the first class of our physician scientist track in the Department of Psychiatry at Mount Sinai. And now I'm involved in many ways in the pipeline of physician scientists. First, I see some, which I mentored during undergrad or even as early as high school in their research interests. And then as clerkship director, I see them as MS3 students. I also teach in brain and behavior, so I see some earlier. I've mentored students as part of their summer research projects and also scholarly years. And then as assistant training director for research, I am on the other side, right? I see their applications coming in for our research tracks. And I'm usually part when they finish residency or their negotiations for faculty positions, and I like to see how they're doing in their careers. So talking about the challenges they face or we face and the strategies that we can implement to improve the physician scientist pipeline is a really important topic for me. So this is to show I have no conflicts of interest for today's learning session. And I'm going to start by talking about why we need physician scientists across all medical specialties. And this may be obvious to many of you, but I still want to make a few points about this. So, there have been really exponential advances in basic sciences over the past few decades, right? So genetics, genomics, omics has really exploded, neuroscience, immunology, advances all over the place, right? And what this means is that there has been an increasing complexity and subspecialization of these basic disciplines, and the technologies change extremely fast. So it really is almost a requirement to have a PhD. 20, 30 years ago, you could be a PI for many years with an MD only or other degree, but now it really, you need a PhD or other advanced degree or training in order to understand all these new technologies that change so fast. And I want to make the case that really those that are physicians or other clinical degrees and scientists at the same time are really needed to translate these basic findings, these basic science findings to the bedside. This is the old, bench to bedside kind of translation, but it's actually supported by data. When you look at and what I'm showing here are the NIH grants by principal investigators who are MDs. And what you see is that they do human subjects research. The majority of their research is either human subjects alone or human and animal subjects. So they're doing translational or clinical research in like 60% of their grants. When you compare these with what principal investigators who only have a PhD do, it's clear that this is exactly the opposite, right? The majority of their research for PhD investigators is animal studies or not human, not animal studies, which I assume are like cell lines or other methods development, things like that. For ND PhDs, it's a bit of a mixed picture, but I wanted to show you this because really MDs are the ones that are doing the clinical research, the clinical trials, the human subjects research. And in the field of psychiatry, we have a great example of this, and the field of psychiatry is what I know best. But I see that there has been really a neuroscience revolution over the past 30 years, and everything has changed, and our knowledge of the brain, neuroscience, genomics has really grown exponentially. But when you look at the treatments, when you look at the interventions, sadly, those changes haven't been implemented in clinical care. So we're lagging behind. And I'm not saying that this is unique to psychiatry. This may well happen across specialties, but I think that one of the reasons for this is probably that the physician-scientist workforce is shrinking. So, in fact, during this neuroscience revolution, sadly, the number of MD PhDs that choose psychiatry as a field has remained steady, about 3 to 5%. So this is what this graph is showing, that between the year 2000 and the year 2012, the percent of MSTP graduates, MD PhDs, who pick psychiatry has been a mean of 3.9%. That seems very meager. And other specialties that study the brain, like neurology, seem to have a similar issue. So what is the status of the physician-scientist workforce? What's the lay of the land, right? So I wanted to understand, and I've been very interested in this since I took over as assistant training director in 2016. So I started reviewing the literature and trying to get some data. So this figure assumes that it takes 15 years from graduation from medical school to obtaining your first NIH grant. And this is actually maybe an optimistic statement, but this is what was assumed for this figure. So basically what it shows is that in 2000, you take the number of graduates, MD, PhDs, about 400 nationwide, MDs, over 15,000. And then you look at how many grants 15 years later, in 2015, were obtained, and we're talking only new investigator awards, so this is the first R1 equivalent grant. 290 for MD PhDs, so we lost about 1/3 already of all that graduated. And when we're looking at MDs, under 500 out of 15,000 graduates. So really very few MDs and less MD PhDs than graduate go on to get NIH awards. We're going to see more fine-grained data. This is like a bird's eye view. But I'm interested in seeing where the pipeline is leaking. So it seems that when you look at the, fresh-faced med students, they're entering med school or they're graduating, they are very optimistic about, between 10 and 20% of them really think they're going to be doing research as, exclusively or very significantly in their career. And when they graduate, so graduating students is the red line, and I'm going to use the mouse to point so that you can see me in the recording. And blue are the ones that are matriculating. So when they graduate, even more actually think that they're going to go into research, right? So it's between 15 and 20%. And now let's see what happens. So in T32 grants, F32 applications and awards, the numbers of MDs and MD PhDs that are applying and obtaining these grants is slowly creeping down. And who's getting these grants? PhDs, right? So nothing against PhDs, but PhDs are thriving in getting these postdoctoral grants. MDs and MD PhDs are not. So when you look at since the year 2002 until the year 2011, the most recent I could find, and this is AAMC survey data, what they were finding is that really PhDs in green are taking the majority of the spots in these postdoctoral grants. These are percentages. And MDs in blue and MD PhDs in reds are not only getting a very small percent, but the percent is also steadily declining since 2002. So we're going to talk about this as well and again, this is a great question. We're going to see more slides where we see, so the numbers are decreasing, but the number of MD graduates is increasing. So it's not just that they are less in terms of how many graduate than the PhDs, but there's a trend that they are going less into research and more to other careers. I'm going to show some data too, but this is a great point. So when you look at research as the major professional activity, and this is again AMA survey data, what you can see is that a very small percent of MDs or physicians have research as their main activity. So on the left, this is the raw number, and on the right, you can see the percentage. So in red, which is the percentage, you can see that the percent has been decreasing. So this is the percent of physicians that do research exclusively or as the major professional activity out of all active practicing physicians. So you see that it's now between 1 and 2%. It's about 1.6, and it used to be, about 5% 30 or 40 years ago. In terms of the number has also decreased, and we'll see that the graduating number of MDs and the number of MDs in faculty in medical schools has increased during that time. So it's not just a matter of numbers. And so where are all MDs going? Certainly not into research, but the number has tripled or quadrupled of MDs that are part of faculty in medical schools, in clinical departments. Actually, if you look at basic departments, the curve goes the other way. So they're leaving the basic departments, but increasing their numbers exponentially in clinical departments. So what I'm assuming is that the majority, so 8.4% of these physicians are doing other things that are not research, so clinical work, administration, other stuff. So now we're going to look at NIH data. So there's this NIH dashboard thing that they released, I think, around maybe September or the summer of last year. And I think it's great because it allows you to look at data on awardees from training, career development, and R-level awards by different variables. So you can break it down by degree, MDs versus MD PhDs versus PhDs. You can break it down by gender, by race. You can look at trends across years. So what I'm showing here is all training and career development awards that are granted to MDs, to MD PhDs or PhDs, so MDs in blue, MD PhDs in green, and PhDs in red. And these are raw numbers. They're not percentages. So what you can see is that the trend is that while the numbers of PhDs who get these awards increases, the number of MDs and MD PhDs remains stagnant or decreases. And this is in the face of increasing number of MDs graduating. So after the K award, and this is data from a K23, which is a clinical degree K. So this is for those that have a clinical degree, they have had clinical training, and they are pursuing human subjects research. And what you can see, and I think this is a worrisome trend as well, is that each of the bars shows percent of those that applied to another NIH application after their K award, which is red and green. And green is the ones that actually received a subsequent NIH award. So you can see what the career path was after a K23. And blue are the ones who did not apply to NIH. They may have applied to CDC or to other agencies. We don't have that data. But at least what we can see is that there's a trend, a clear trend, that when you advance in time, more and more people are not even bothering to submit, for various reasons, an application to NIH after their K23, or if they are applying, they're not getting the grant, right? And we should be looking at this data until about 2003, because the data for these years actually may still change, since it's not been still 4 or 5 years since they got their K. But if we even just looking up to 2003, the trend seems pretty clear. And now on this slide, what I'm showing is on the top the number of applicants, and on the bottom the number of awardees. And this is a busy slide. I don't want you to be looking a lot at it, but just the broad strokes are that red bars are PhDs, and the tiny blue and green bars are MDs and MD PhDs. So while applications and awardees are increasing, there's a rising trend among PhDs. The opposite is happening among MDs and MD PhDs. And in grant review panels, in committees for scientific review, also grants are majoritarily being reviewed by PhDs, and MDs and MD PhDs are underrepresented. And this is a big change from 30 years ago. And on this one, the only thing I want to highlight, this is again a busy slide, but the only thing I want to show is that you have the breakdown of MDs on the left, MD PhDs and PhDs, and these lines at the top are the pay lines. So this is the funding rate, and here you see the percentages. So pink are the experienced investigators, and they're getting the highest pay line, the highest funding rate. Then you have in blue the early stage investigators, those that have graduated recently from their terminal degree. And then the pay line is lower. And then you have the new investigators in green, and these are the ones that have not had an R01 equivalent grant yet. So these are new to the research career, and these have the lowest pay line. So this is very concerning, and this is up to very recent data. This is the latest I could find from 2016. And this is across MDs, MD PhDs, and PhDs, so it's not specific to physician scientists, but I wanted to point it out because it suggests that the workforce in general in research may be aging and not letting the new people in. So what we also can see is the same pattern as before. I want to point out that on the PhD graph, this number goes up to 12,000, and the MD PhD and MD graph, it goes to 2,000. So the numbers are very different in the PhD and MD PhD MD pools. So this is a summary in terms of the trends that we're seeing is that on top of that, in MDs, new investigator applicants, those without an R01 equivalent grant, decreased. The trend is a big decrease over these years. And in MD PhDs as well, while PhDs keep stable or increase. And does this have anything to do with age? So one thing that has changed since 30 years ago is that the age at which you got your first R01 equivalent grant has crept up and up and up. So that now, first R01 is about 44, and then renewal is about 48. So this is, it's getting really to an age where people are juggling, physician scientists are juggling all these different things like loans, trying to get, a good salary, and there's still no parity between the research salaries and the clinical salaries at most institutions. So I think that may have something to do. The age to first faculty appointment has also been creeping up as well. And this is the gender data that I was discussing before with Sandy. When you look at both MDs and MD PhDs, the number of men in blue bars is much higher than the tiny pink bars. The good thing is that the pink bars with both applications and awards are rising. So it's a good trend. And the pay line, the funding rate is a little bit lower in female applicants, but it's getting very, very close to the male. So I think that this is a little bit hopeful data. And this was presented by Kay Lund from the NIH, which created a new biomedical workforce division specifically to address gender and diversity issues in the biomedical research workforce. So what happens in terms of diversity? And the picture is not very promising yet here. The numbers are increasing, but they are still much lower than what would be expected based on representation in the general population. So what you can see here is that, first of all, the pay line, the funding rate, is significantly lower across underrepresented minorities compared to majority applicants in blue. And the length of the bars, actually the scale had to be broken because, the majority applicants are around 22,000 and the underrepresented minority are under 400. This is NIH-wide, and this is R01 equivalent. So it's really a very small pool of underrepresented minority applicants. And when we're breaking down underrepresented minorities by specific races, ethnicities, what we see, and this was data from MDs, MD PhDs, and PhDs, and we're now seeing data from MD PhDs on top and MDs at the bottom. And the picture is exactly the same. And we see that in terms of numbers, white is way higher than the other races and ethnicities. And in fact, in particular, Hispanic are like almost close, and Native American as well, but Hispanics are really underrepresented compared to their proportion in the general population. They're very close to the zero line. So now that we've shown a little bit of the data and the lay of the land in terms of the pipeline and the physician scientist workforce. So what are some of the specific challenges that we have identified? And one thing that I have noticed is that there are some critical periods in terms of making or breaking someone's decision to continue on a research career, right? So first they have to be exposed to some research, maybe in high school, maybe undergrad. Some people only figure it out in medicine or maybe later, but there's a point when that research spark needs to ignite. And I know Mount Sinai, we have great programs for undergrads and for high school students, so there's a lot of outreach that is being done there. There's a gateway issue in MSTP programs with access by diverse applicants. And in respect to psychiatry, there's and this may be applicable also across specialties, a big issue is exposure to psychiatry before choice of PhD field. So if you're not aware of the research that's going on in psychiatry, you're not going to go into research in an MSTP program in neuroscience or psychiatry. The choice of residency training, a specialty, that's another big point, and choosing a research track or not, that can make or break your research career, I think. A transition to faculty as well, being in an institution that provides protected time versus one that doesn't. The transition from a K award to R01 equivalent grant, that's also a very delicate point. And renewal of the first R01 with issues such as, is there bridge funding provided by the institution or by the department if it takes longer than expected to renew your grant? So one of the things that I've noticed since I've been mentoring residents in the research track is that really the flexibility in clinical training, allowing more time for research and avoiding gaps between research training periods is extremely important, because as I'm going to point out in a few slides, research skills can very quickly become obsolete with the speed of knowledge exponentially growing, and methods that were useful 3 years ago may be totally yesterday's news if you're trying to submit a K award now. So early outreach during medical school to address inaccurate perceptions of specialties, as I mentioned, is a big deal with psychiatry because there's still a lot of stigma. And very often students only choose psychiatry after doing their psychiatry clerkship and really seeing clinical rotations in psychiatry. So that's usually too late for the MSTP students. And another thing I want to mention is that when we looked at that graph of intentions of medical students of doing research after med school, and it seemed, 10 to 20% really wanted to do research, this has actually been shown to fluctuate. So if you superimpose that graph with a graph of NIH budget appropriations and purchasing power, it actually overlaps. So you see med students are, they're very well informed and they're looking at these things when they're making their decisions, or they are influenced in a subconscious way. But it really fluctuates. If the NIH budget's going up, more people are applying to MSTP programs and to K awards than if the budget's going down. So one contributing factor to the shrinkage of the pipeline, I think, is the indebtedness, right? So the student loans. And what we can see here is the average debt of med school graduates and how it's been growing exponentially since 1982 until recently. And it's still growing, but I couldn't find more recent data. And what this is plotting is what's happening with the NIH salary cap, and a similar thing is happening with the K award stipends. They're not growing at the same rate, and they're not growing at the same rate as, in pink, the actual physician salaries. So what's going on is that there's this gap that is currently being bridged creatively by departments and institutions, but without any specific support or guidelines to do so. So I want to briefly talk about some of the strategies that are being implemented or that we hope to be able to implement across specialties and both at institutions, and some things that the NIH is doing or the VA or other stakeholders to really amp up the pipeline of physician scientists and address some of these challenges. So the NIH, it should say NIH, not NIMH, is doing a lot. So there's this new division that's promoting the diversity of the scientific workforce and early independence. There are specific programs. So besides the K awards, there's also this new R38 grant that actually the NIMH is not participating in. There are administrative supplements specific for clinical residents and fellows. So we actually have one of our residents who got this administrative supplement. There's R25 grants, which we also have one of those as well to fund one of our research tracks. There are VA initiatives like the Career Development Award at the VA. There are Foundation Career Development Awards. And then the AAMC has this initiative of which I am part, which is a committee for creating a physician scientist training and career development home. And I will talk a bit more about this in a bit. And I'm curious to hear, the academic institutional perspective from all the departments. So I'm going to try to finish, with like 10 minutes or at least, so that we can have some discussion, because I really would like to hear from all of you about your experience. I'm going to just briefly present an example from our department and what we're trying to do with our psychiatry research tracks. So the first one is our quote-unquote regular physician scientist track. Like, this is what most departments of psychiatry mean when they say they have a research track. So it's a track that's designed mostly for MD PhDs or those that have a very substantial experience with research. And the goal is to launch an independent career after residency. So it takes 4 years, which is the same duration of the usual psychiatry residency. And in our department, we have this track that has been going on. Ron started it in 2008, and this is the one I graduated from. So we have 2 positions per class every year. And this is the structure of the track. The PGY 1 year is not even listed because that's an intern year that we have no leeway in squeezing research in. And we find that in general from feedback from the residents, it's not very useful to have an isolated research month or period in the first year. But after the first year, you'll notice that red is protected time for research. And it really covers, important chunks of all years and the majority of the PGY 4 year. We know we are lucky in psychiatry that we can do this because the ACGME requirements are very modest compared to the duration of the residency. So in other residencies, they don't have that luxury. In psychiatry, if you want to do a child fellowship, you can fast track and do the residency in 3 years. So only really 3 years is what you need to complete a residency. So what we're doing is we're basically giving as much protected time as the ACGME allows. And we are finding that that really makes an impact in the ability of our graduates to be competitive and to keep their research skills so that they don't become obsolete during their clinical training. And this is an example of what we are expecting of them. First year, they're consolidating their choice of mentor. They're starting to attend lab meetings. They may wrap up some papers from their PhD, and they are maybe writing a review paper on a new topic. Then second and third year, this is really the bulk of the work they're going to be doing, either start analyzing existing data or really acquiring pilot data if they're doing, their own pilot studies. And this is the time to apply for small foundation grants, internal funding, and acquire and keep up to date all your technical skills. And then what we encourage everybody to do is in the beginning of the fourth year at the latest, submit your K award. So then, it probably is not going to be funded on the first round, but then you have a second chance, it can review and resubmit before you actually have to negotiate your faculty position, because you're going to be in a much better position to negotiate if you have a funded K award. And this is the more innovative track that we have, and this is the one that Ron Reeder applied for in, I guess, 2015, 2014, yeah. And then Antonia is the PI, so we worked together on the renewal, the first competitive renewal, which we got last year. And we are now on the 5th year of the grant, and we already have one graduate. And this is funded by an R25 grant from NIMH. It's a combined residency plus PhD program. So it allows residents to complete residency in psychiatry, which normally takes 4 years. So instead of 4 years, they're doing 7 years, and then they're getting a PhD as well. And I'll show you the structure of the track. And the reason that this track was born, I already mentioned some of these issues, but it was an attempt to address some of the limitations of the current pipeline of MD-PhDs. So the MSTP MD-PhD programs are great, and they, train the majority of physician scientists. But the problem is there are several issues that limit their importance in psychiatry. So first of all, only a very small portion of MD-PhD graduates from MSTP programs go into psychiatry, as we saw, about 5% or less. And then very often when they go into psychiatry, the field of the PhD has nothing to do with their clinical interest later on. And in some cases, it's very difficult to translate those skills to useful skills for their new research career. And in addition to that, the design of the MSTP program basically requires being away from research for at least a minimum of 3 years, counting the intern year, and in most residencies for 5 or 6 years. So, as I mentioned before, your technical skills are obsolete, and you basically have to retrain and do a long postdoc after residency in order to go back to research. So what we did in the track is that you see that research really starts on the second year and third year. So about half of the second and third year are divided between research and PhD didactics. And then by the end of your third year, you should have already written your PhD proposal, you've completed your didactics, and you're defending your proposal, getting it approval, and you'll work on it for the last 4 years. And while you keep a few, it's not shown there, but all residents keep, a couple of clinical longitudinal cases over the 5th, 6th, and 7th years to keep their clinical, licenses and to keep their clinical knowledge. But really, most of the last 4 years are research. And the salaries are funded half by the R25 grant and half with a regular resident line over the last 6 years. So it's done on a cost-effective way, and it's actually cheaper than the traditional MSTP approach. And they are also getting a loan repayment, or they can apply for loan repayment program starting in the second year, because they're doing 50% or more of their time of research. So now I'm very briefly going to talk about the AAMC committee that I'm part of. And actually, I saw that they sent their survey already to the MSTP here at Mount Sinai, so I have to find out if they responded. I'm hoping they did. But so basically, the reason for the committee is that although there have been all these calls to action, by the NIH, the AAMC, and all this data that I showed you, there are some initiatives by NIH and by institutions and departments, but in almost no institution are these initiatives really cohesive. So it's something that basically each department is reinventing the wheel, or each institution is treating physician scientists at different stages as separate entities. So what the home means is that there will be some infrastructure or some program that works with the physician scientist at all stages of training, from MD, med school, all the way, to if they're doing their PhD, residency training, fellowship, faculty, first faculty position, and then retention throughout their career. That's a very lofty goal, but I'm hoping that there can be something, because I think that this will be much more cost-effective, integrated, and synergistic in terms of resources than having each department do this for their trainees. So this is the charge of the committee. So first, and we are at this stage now, it's defining what elements this physician scientist home needs to have and what are the consequences of establishing one. Then the second is to identify what key educational principles all physician scientists should obtain throughout their training and career development. The third is to identify what would be the key institutional components, and there are many components. We can go into the details during the discussion if you're interested, and then present several models. So looking at what institutions have been most successful, and we're now about to send the second survey, which will not be for MSTP programs, but for the whole institution at the dean level, to really talk about what they're doing in each institution to consolidate this physician scientist home, if they're doing anything. And then we're going to try to learn from the programs across the country that seem to be most effective. So I would like to open it now to open discussion. I hope that this has been an interesting presentation, and I look forward to hearing your comments and ideas. Thank you.